Like it. No, yeah, come here. Unless I because so I'm trying to stretch now. So sorry. Yeah. Two. Five. The second. Lo so. To a hugu zan harawa sa uskuciye koro wolo no ma. Da wani zauriya ba. Wanga, da mayon. A kwanga. Sai na. Duka kala ne.
I'll go, man. No, thank you. Mm.
Hello.
Good afternoon, everyone. Welcome to this week. We are going to manual therapy techniques that was done previously on cervical and lumbar degenerative conditions. And here with us is Prof. Skumbi. He is going to demonstrate the techniques that were discussed earlier.
Basically, manual therapy techniques to both the cervical and the lumbar spine. We have specific techniques, and we have some techniques. You direct the effort of manual therapy straight to the joint that you want to treat. Whereas in general technique, even though you have 3 or 4 joints, so that's the one we call general technique. You'll be moving a joint that is not affected. And if that joint is already hypermobile and you are moving it again, it can cause pain. But general technique is much more tolerated by patients than specific techniques. So in this demonstration, I'm going to start with general techniques, then I'll move to specific techniques. Then we can then talk about individual school of thought. Thank you. So for the general technique, patients will sit down. Let's get can you capture us very well?
Yes.
So for the general techniques, it's not limited to any technique. You just want to mobilize the joint, like what we call warm-up exercises. You just want to mobilize the whole joint. Patient will shift like this, okay? So you get one of your arm with your elbow bent this way. That is where the head will come. At least I might need to around here. So this is already anchored in the elbow. This guy's face is see, they can get something to clean the sweats on his face. You know, or something like that. A towel or something. He has some sweat, so it's leaking off. Sorry, just there we go. That's sweat. I think he has been running to meet up. So the head is like that. Now, this hand is going to be below the area you want to treat. So the hand would be below the lower area and stabilize the area like this. And the upper hand will move the head with a little bit of traction, and then you will move it like that. While this one is stabilizing, then this one will move it with rotation towards the therapist side.
There's no light. It's dark.
There should be this likely thing now. Rain. I think we should move to this place.
Yes.
Maybe you should pause the recording. People are not, at least you are not ready for the session. You are not ready. If you are ready, you are putting everything ready now. You don't have to be struggling. If in my office, I do recording my office. You are getting everything ready. We are not going to have issues when we're doing this lesson. Maybe you can move the chair closer to this place. So you might have to start off like this. Because you might have to come to the back to capture the screen as well. You start from front and then you move to the back. So can we start again? Just let me start again.
Yes, we can start.
So like I'm saying, in the general technique, you have the elbow of the proximal hand will go like that. It's just to warm up the neck before you start the mobilization. That's why it's called a general technique. So this one holds the head like this. Okay, so we've seen that. So at least you have to come to the back now. So the distal hand, this hand is going to stabilize the neck. So the proximal hand will apply a little traction with the therapist coming from the lower side to upside like that, and then you just rotate like 10 times. Okay, just like 10 times. Or if the patient has problems moving the joint, with this one you are doing, the patient will not experience any pain at all. So you can do 10 to this side and you do 10 to the other side. That's just a general technique to start with mobilization of the neck. Now we can now use a specific technique. All right. Like that. We're going to carry out technique with midline oscillation. We will look at serious. We will look at the other school of thought. The snacks, and the movement with mobilization. All right, please go on. This pillow will be on your chest. Okay, so you see, if there's a face hole, the patient should just lie down with the head directly into the face hole. But if there's no face hole, the modification we can make, get me one more pillow, please. One more pillow. The modification we can make is
We have lost the sound, please. Hello, sir. There is no sound again. We can't hear you.
And grade 5 is a trust. Okay? It's all about applying oscillation to the site of the pathology. And you expect all the neurophysiological mechanisms to result into pain reduction and then more mobility. This one is a specific technique. You need to go to the specific joint. And normally before you start, you have asked your patient to bend their neck. When they bend their neck,
What is really happening?
assume that this patient is having cervical spondylosis that's affecting C5 and C6. Now, you need to realize that spondylosis takes place in the facet joint. Although the pain can be radiating to the central part, but the main site of pathology is in the facet joint. So when you are using Maitland, you are going to deliver oscillation both below the spinal process and on the facet joint. That's the principle you need to understand. Another principle you need to understand is that when you are using Maitland grading and you want to achieve flexion between C5 and C6, how do you deliver the oscillation? You want to achieve extension between C5 and C6. How do you deliver the oscillation? You want to achieve rotation and side flexion. How do you deliver the oscillation? Those are the components of Maitland grading. The problem is between C5 and C6, between here and here, between C5 and C6, and you want to encourage flexion. What you will do normally is go to the upper cervical vertebrae, which is C5, and you deliver posterior thrusts in an oscillatory manner. In this way, one thumb is already below the C5, or it's on C5, the other thumb is reinforcing it. Keep your elbows straight, move your body over your elbow, and then you go in an oscillatory manner like this. Can you see what I'm doing? So you hope to deliver if you deliver two oscillation in 1 second, you go like this. If the patient can tolerate it. If the patient cannot tolerate it, then you can deliver one oscillation in 1 second, whereby you go like this. Okay. And you have to do that minutes, which is 60 seconds. So imagine you deliver two oscillations in 1 minute, you would have delivered 120 oscillations. If you are delivering one oscillation per 1 second, you would have delivered 60 oscillations. Remember, we want to encourage what? Flexion. Between C5 and C6, you will go to the upper cervical vertebrae, which is C5, and you deliver what? Posterior anterior thrusts, not the lower cervical vertebrae. All right? If you have delivered it for 1 minute, ideally manual therapy, you ask the patient to stand up, the patient will sit up and you reassess. You have to reassess the patient by asking patients, bring your chin down to your chest. This one. Look at the ceiling. Come like this. Come like this. I've done a quick assessment. If I notice improvement following that assessment, I will repeat the same procedure 3 times. You understand? So the treatment is not hard. Just posterior thrust on the spinal process of particular 120 oscillation. They assess the patient. If there's improvement, you repeat it 2 to 3 times. I hope we got that. Now, what happens if we want to encourage extension with Maitland oscillation? Yes. If you want to, the problem again is between C5 and C6. You want to encourage more extension. The principle is that you will still go to the upper cervical vertebrae, But this time around, we are going to do anterior-posterior thrust, not posterior-anterior thrust. We are going to do caudal anterior-posterior thrust. So you go to C5 and then you push down like this. So you're pushing from anterior to posterior. I'm still on the spinal. I'm pushing down. You can see that his neck is actually dribbling into extension. It's drifting into extension, even as I'm moving. Again, you can deliver 2 oscillation in 1 second in this manner, or you can deliver 1 oscillation in 1 second in this manner. When you do it for 1 minute, you will reassess extension. If extension has improved, you will repeat it 3 times. I hope you got that. If you want to encourage rotation, what you will do, you will go to the side of the cervical spine where rotation is limited. For example, this patient is lying down this way. If rotation is limited to the left side, I think it's the left side. Go to that side. And this time around, I will identify the problem is between. You go to the side of the spinal process of C5. So I am not on top of the spinal process of C5 again. You go to the side of the spinal process of C5 and you deliver a transverse oscillatory pressure like this. If I'm doing this, his neck and head will be rotating towards me. So this is what you do. You can do 2 oscillation in 1 second, casting like this. Or you can do 1 oscillation in 1 second, depending on what the patient can take. Now, this movement is called transverse oscillatory pressure. Okay? You will do it at C5. You will also do it at C6. You remember, can we have a quick recap? If you want to encourage flexion, and the problem is between C5 and C6, you do posterior anterior thrust on C5. You want to encourage extension, you will do anterior posterior thrust on C5. You want to encourage rotation, you go to the side where rotation is limited, and you will deliver transverse oscillatory pressure. The prescription is the same, either 60 to 120 oscillation per minute. You will assess the patient. In the potential improvement, repeat it 3 times. Now, let's talk about side flexion. How do we achieve side flexion? Now, to achieve side flexion, you have to follow the Fried's third law. You know, Fried's law. There's first law, there's second law, there's third law. And what Fried's third law is saying is that if movement in one plane, when it's fine, it's a neutral position. If movement in one plane is increased, the movement in the opposite plane will be reduced. So as we are increasing oscillation, as we are increasing rotation on the left side with the transverse oscillatory pressure, side flexion on the right side will also be increasing. That's the principle. On the left, side flexion on the right will also increase. That's the principle. But specifically, if you want to address the side flexion on the same side, then you will need to go to the facet joint. You know, all along we've been working below the surface. So if you want to identify the facet joint, you can roughly identify using your thumb. 1 thumb distance away from the spinal process will approximately land you on the facet joint. But it must be the dimension of the thumb of the patient, not your own. So if your own thumb is bigger than the thumb of the patient, you will still measure with your thumb and you reduce it a little bit. Then I'm on the facet joint now, and you can deliver vertical oscillatory movements on the facet joint. That will also help with side flexion on that side and rotation on the opposite side. Rotation and side flexion take place. I think we understand it. So facet, to locate facet joints, almost 1 thumb away from the spinal process and slightly below, you will land on the facet joint and you can deliver vertical oscillatory pressure, either 2 oscillations per second or 1 oscillation per second. The other method of identifying passage joint is to draw all the muscles at that segment, draw it until you feel a resistance. Then the point where you feel the resistance roughly is the position of the passage joint. So you can deliver VOP, vertical oscillatory pressure, on that place. For the prescription that we have mentioned, 60 to 120 seconds, we assess the patient. If there's improvement, then you repeat. That, in a nutshell, is how to use midline oscillation to relieve pain and increase mobility either in the cervical, thoracic, or lumbar spine. It's the same principle. I hope you get that right. Now, we're going to go to the second technique, Mulligan technique. If you want to use Mulligan technique, I don't know whether we discussed in our last class, but I think that Mulligan concentrates on gliding a joint. You apply a glide to a joint and you ask the patient to repeat the movement that the patient has found painful. Basically, that's the summary of Mulligan. But he actually came up with 3 techniques. There's NAGS, N-A-G-S, which is natural apophysic glide. There is NAGS, sustained natural apophysic glide. Both NAGS and SNAGS are used for the spine in Mulligan. Then the third technique, we call it movement with mobilization. That one is used for the peripheral joints, like shoulder and hip. I'm going to demonstrate this one in a short while. Well, NAGS for the cervical spine is best illustrated in a seated position. Is both illustrated, NAGS is best illustrated in a seated position. Again, the positioning for NAGS is very similar to that general mobility that we did. Your hands comes like this, okay? And then you identify the segment where there's pathology. Let's say C5 and C6. This little finger, cupping finger, will go below the spinal process in the area that is affected. Then the thinner eminence of the opposite hand, this thinner eminence will cover, is going to cover the little finger. Then you push down to get the end of movement. I got a feel of the end of movement here. Then you release it by up. So I'm in the inner range. And you keep pushing from middle range to inner range, 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 middle range to inner range. So that is not. We have provided support by gliding the joint, and then we now apply the rotatory movement. This NAGS is particularly good when the patient pain is so high and the patient do not want anybody to even touch maybe like 8 or 9 over 10. Because it's a very simple movement. You put your hand below the spinal process, you cover it with the limit, you reduce it by half, and you continue from that mid-range to inner range, mid-range to inner range, mid-range to inner range. That is natural apophysic glide. For sustained natural apophysic glide, the patient can still be in a seated position or lying position. If you want to do SNAGS, sustained natural apophysic glide, we can do it centrally below the spinal process, and we can do it unilaterally on the facet joints. So let's do the central SNAGS first. Again, you place your thumb below the spinal process, and you allow your thumb to go in the direction of the eye, because that's the inclination of the facet joint. So you are not pushing like this, you are not pushing like this, you are pushing like this. Okay? So this is how your thumb will be positioned, inclining towards the eyes. Tell this man to keep his head up. Now I'm providing the glide now, and we are now going to ask the patient to carry out the movement which is found painful. For example, if it is flexion, with this my glide, now ask the patient to flex, please. So he will be flexing and my hand will be following. Tell him to come back. As he's doing extension, my hand is still providing the support. Flexion again. Extension again. You will notice that my thumb is constantly providing the glide. And you notice that my other finger is not touching the neck, so that I will not occlude on his trachea or press on his jugular vein. What about with rotation? If the patient wants to do rotation, you still maintain the glide. You tell this man to rotate to the right or any direction. As it's rotating, you also follow the glide. Tell it to go to the opposite side. As it's rotating, you also follow like that. Okay? Like that. So we can do flexion, extension, side flexion, and rotation. What's the prescription for this? Mulligan advised that we should get 10 movements in each direction. 10 of flexion, 10 of extension, 10 rotation, and 10 side flexion. And if that's improved, repeat it 3 times. Okay? So that is Mulligan, NATS, and SNACS. Now, movement with mobilization. Movement with mobilization is specifically meant for the peripheral joints. Let us assume that this our patient is having problem with moving the shoulder, for example. Right? We can do movement with mobilization of the cervical spine to encourage movement of the shoulder. What we do, basically, the assumption of Mulligan is that as the hand moves into of flexion, the corresponding spine process at the shoulder is rotating in the opposite direction. That's the assumption. Can I repeat that? As the hand moves into abduction, the corresponding spinal process at the level of the shoulder is moving in opposite direction. So what do we do to help the patient? You will glide to the side of the spinal process corresponding to the shoulder, and you maintain your glide. After that, you now encourage the patient to do the movement of the shoulder, which he found painful. So lift up, and down, up again. And the patient should find it easier this time, and down. Okay? Can we instruct him in flexion? Move it up and down, up and down, up and down. That is movement with mobilization. It's meant for the peripheral joints. The same way we apply it between the cervical and the shoulder is the same way we are going to apply it between lumbar and the hip joints. The same principle. I believe we got that one right. So we have discussed midplant and model. We are going to serious. We are going to show serious technique. Let's do some preamble talk before we demonstrated serious. Now, serious technique is best when you have a patient that's having dyspogenic nature of dysfunction. You know, disc is out or something is causing impingement on one side of the neck, such that the patient comes to the clinic almost like this. Almost like this. So because the patient comes almost with this posture, he's turning his neck away from the side of the pain. The patient is going to have more limitation rotating to the left because of the pain, and it's going to have little or no limitation rotating to the right. So before you use serious technique, you will identify area with least movement, area with more movement. So if the patient is having dyspogenic posture like this, the area of more movement will be the right. Area of least movement will be the left. All right? You need to identify that. After that, you can now ask the patient to lie down. You can ask the patient to lie down. The stomach. Up. And then you get hold of the head of the patient like this one. Remember before this time, hold on this one. You remember this time we have identified the area of what? This area of more movement. Now, serious application is to work in the area of more movement. To get full range of motion in the area of more movement before we now go to the area of least movement. Okay? So, and there are 3 movements that we are going to use. We are going to use straight, 5 movements. We are going to use straight foot. We are going to do rotation. We are going to do side flexion. We are going to do 2 planks. All right? first movement out of those 5 you carried out in the patient is a straight pull. Remember, the patient neck is like this. It's like this when it comes to the clinic. So it's more movement here, less movement here. You will move the neck into central. You will put one hand on the occiput, one hand on the shin, your leg at the support of the leg, and you lean your body away like this. All right? You lean your body away and bend the knees like for a few minutes. All right? For 3 to 5 minutes. And then you relax. You will see the patient neck will systematically move from this side back to this side. By the time you do the straight pull and the neck is down in the center, that is when you will progress to rotation. Carry out the rotation, your pull is still the same. You can stay like this or you face the area you want to rotate. Okay? I will maintain that traction and rotate like this. Let's say this is the limit the patient can do. I can mobilize or I can apply a thrust. How do I apply a thrust? I'll maintain that traction and I'll go like that. And you can get a full sound to reassess the patient and you do it 3 times. Let me repeat that again. You can go like this, maintain your traction, you can rotate to the end, and you can mobilize. If you don't want to do thrust, just do your oscillation. And if you want to do thrust with this hand, you deliver high velocity, low amplitude thrust. By the time you've gotten full rotation on the area of more movement, you now move to side flexion in the area of more movement. How do we do that? Apply traction. This leg, anchor it on this side of the face. The other leg, you move it like this. You see that automatically, the patient neck is already in side flexion. And you can mobilize if you don't want to do thrust. If you want to do thrust, just do it like that. And I repeat that again. Traction like this. Swivel your leg. Maintain that traction. And then use abduction to produce the high velocity, low amplitude. If you don't want to do thrust, you can just mobilize. By the time the patient has achieved full side flexion, you know where we're coming from. We have achieved straight pull, we have achieved full rotation, we have achieved
right.
now without too much traction, you now rotate from side to the side. Now you now have full rotation. If as you are doing that, patient complain of pain, you will wait until the pain subsides. When the pain subsides, you continue. When you achieve full range, you now gently move the side passively. If the patient complain of pain, you wait. When the pain subsides, you move more. So you see, we have done straight pull. We have been able to keep the neck straight pull. We have achieved full rotation to the painless side, full side flexion to the painless side. We have been able to do passively full rotation on the painful side and side flexion on the painful side. Now, what we have to do now is to glide. And in serious, we have 2 styles of gliding. There's anterior-posterior glide and there's lateral glide. In the anterior-posterior glide, your posture will change. One hand will be at the occiput, the other hand will be anchoring on the mandible. Okay? The lower hand will push the head up and the lower hand will jack it down like this. That is anterior-posterior glide. Okay? Now anterior-posterior glide. The lower hand push it up, the upper hand apply a rather high velocity, low amplitude movement. Okay? That will help to increase extension and flexion. After you've done that, like 10 repetitions, you will now do lateral glide. The lateral glide again, this is how you stay. The 2 hands will be on the occiput. You put the head of the patient in your abdomen and you shift your weight from one leg to another. So you are gaining side flexion. So remember the other time I said side flexion comes with rotation on the opposite side. That's how the spine works. So you do that. You do about 10 of that, you are assessed to sit up.
That is what serious advocates. Okay? Patient come with dyspogenic, identify the area of least movement, area of more movement, mobilize or manipulate the area of more movement to full range. Now go to the opposite side. Now your line. I hope it is clear. The lumbar spine. The technique is practically the same in lumbar spine. All right. So you know the leg plan is the same. The same way I described leg plan for cervical. That's how we are going to do it. But the mulligan, I will repeat the mulligan for the lumbar. Now, if you want to do mulligan on the lumbar, you know there is a snacks, and movement with let's start with nuts. If you want to do nuts, you remember nuts is that small movement from mid-brain to inner range. Again, you go to the area of pathology. This is the area of pathology. Now, you will not use the form when you are working on the spine of the lumbar process. Because the spinal process and that of the salon, you will have pain. So you have to use the pisiform. You have to use the pisiform bone here to mobilize. So you use your pisiform bone like this on the affected segment to reinforce it with the other hand. Again, you push to the end. So I've seen the end now. Reduce it by 50%. So I'm in the middle range now. So you'll be going from inner range to middle range, inner range to middle range, inner range to middle range, inner range to middle range to inner range, middle range to inner range, middle range to inner range. You understand? That is natural apophyseal glide for the lumbar spine. What about snaps? Sustained natural apophyseal glide. Sit up. Camera will have to come in. To sustain natural apophyseal glide in the lumbar spine, you will use the space between your thenar and hypothenar eminence. Put it on the affected segment like that. Okay? To provide the glide, and then you ask the patient to do the flexion, then as the second. What's that? While you are doing the glide extension, flexion, you provide the glide extension. Can we ask him to do rotation? As he's doing rotation, you are helping him and you are maintaining the glide. Rotation, you are maintaining the glide. Rotation, you are maintaining the glide. The therapists have to concentrate on the glide. And one of the principal mulligan thoughts is that your glide does not. If you apply your glide and patient says it's painful, you have to reduce it. And the procedure itself will reduce less pain. While you are treating the patient and less pain after. If you cannot achieve those two, you will not use. I hope it is clear. So that is snacks and snacks for lumbar spine. Serious for lumbar spine. Serious is always concerned about something is blocking. How do we train? How do we do lumbar serious for the lumbar spine? There are two methods or three methods. We can do stretch manipulation or reverse stretch manipulation or leg crossover manipulation. Those are what serious are. Now let's talk about the stretch manipulation. The patient will lie down like this. Okay. One, the upper leg, the patient will lie on the inside. So this will be the affected segment. The leg, the foot on the affected side will be anchoring around the computer fossa of one leg. All right. The therapist will stay here at the back. The proximal hand will be on the inhale first. Patient upper limbs will be like this. Your hand will be on the pectorals, not on the humerus. That's not possible. You will now distract the joints equally. You put this one forward and you put this one backward until there's no more movement. Okay? So that's taking off the slack. We have already taken off the slack. You can ask the patient to breathe in and out, and you can apply sudden high velocity low amplitude with this hand, not with this one. I'm going to repeat it again. With the stretch manipulation, patient lie on the good side, the affected side is uppermost. The foot on the affected side is going to flexion at the wrist and knee, and the foot is behind the popliteal fossa. The upper limb on the upper side is thrown into position of rotation like this. One hand of the therapist will be on the pectoralis muscle, the other hand on the you push them apart until there's no more movement. As the patient is breathing in and out, the liver talks with his hand. You will assess the patient. The patient feels better. No. It's good for SID as well. The same procedure can be good for SID. If I'm doing the procedure and I'm staying like this, the patient will feel more in the middle spine. If I'm staying like this, lower spine. If I'm staying, applying the procedure like this, it's the SID. You understand? Now, serious call another technique, reverse stretch. In case this stretch does not work for your patient, you do reverse stretch. No, with stretch manipulation, this is the position. So in reverse stretch, this arm is going to go like this. And this leg, this one is like this. And this leg is going to go like this. So we see we have reversed the position. So again, you push this one forward and this one backward until when there's no movement, and use this one to apply the force. You have to lock the joint, and this hand will apply high velocity, low amplitude movements. You will assess the patient. If the patient improves, you do it 3 times. The third technique of serious is called leg over. In the leg over method, the position is very similar to stretch. But the leg will be over the edge of the knee. Can you see that? That's why it is called leg over. Okay, and therapy stays here. Again, you move this one down, this one to the rear, and the sudden force is applied. We assess the patient. Patient feels better. Are we good? All right. That is serious. So we have demonstrated molecular and midline and serious for the lumbar spine. SIK. It is a sacroiliac joint. Stand up. We need to work harder on this SIK. For SIK problem, you have to have carried out assessment, qualitative tests of SIK, Gisling test, lumbar compression test, high thrust test, compression test, distraction test, active straight leg bracing, bilateral active straight leg bracing. There are many. But 3 of those tests must be before found that the patient is having SIK problem. After you have done that, this is also very important. You have to carry out Gillett test. The test we call Gillett test. The patient will stay in front of you. You put your hand on the 2 posterior inferior iliac spine, your thumb, like this. Ask the patient to lean forward. Please tell this malam to lean forward. Forward. And watch the position of my thumb. You can see that they are not going together. You can see here that the right thumb is going faster than the left. What's the implication of this? If the patient is having pain on the right side, that means the right SIJ is hypermobile, and you will not deliver manipulation on the right SIJ. You will come and deliver manipulation on the left, which is the unaffected side. Why is it like that? Why is the right SIJ hypermobile? The sacrum is stopped on the left. So the iliac on the right is producing compensatory movement for the lack of movement of sacrum on the left.
That is why if the region of pain is the one that is hypermobile, you will go to the opposite segment and deliver manipulation or mobilization. If on the other hand, you place your hand, now lean forward, go forward. If on the other hand, the thumb that is hypomobile is the affected area. So that shows that that affected SIJ is hypomobile. And that is where you are going to deliver manipulation or mobilization. I hope it is clear. So before you move into manipulating SIJ, you need to carry out and confirm that 3 provocative tests are positive. You need to do Gillet tests to know where you are going to deliver your manipulation, whether the affected side or the unaffected side. The next question I want to ask is this: what sort of movement are we going to deliver? Then we say what sort of movement takes place in the SIJ. SIJ is practically a joint between the sacrum and the ilium. And when the pelvic is tilted anteriorly like this, we call that counter rotation. But when the pelvic is tilted out like this, we call that rotation. Those are the 2 movements. So when we are doing movement, manipulation, mobilization, we want to manipulate or mobilize either into counter rotation or rotation. And by convention, we have to start with counter rotation. If your patient has a SIJ problem and you have established there is hypomobility, you first of all try counter rotation. If the patient pain did not improve, then you go back and do rotation. Let me show you some techniques of counter rotation. Please come. We'll soon finish. Okay, for counter notation, if this is the SIJ that is hypomobile, or if this is the opposite side that is hypomobile, when the affected side is hypermobile, we are working on this side. The therapist will stay opposite to the affected segment. The space between tena and tena eminence will rest on the SIJ like this. And the therapist will grab the leg and the knee like this. All right, rest your leg like this. So you move the leg up and you push down on the SIJ until there's no more movement. If you want to mobilize, you just go that oscillatory movement. You can do oscillation. And if you want to manipulate, you move until there's no more movement. And with this hand, you deliver the high velocity, low amplitude movement. Okay? That is counter notation 1. That's the first method. Let me talk about the second method. The second method, tell this guy to lie on his side and face, or you can face like this so that we don't confuse our audience. So the patient will lie on his side. You might have to go to that side. Therapy for the counter notation second method. So the patient will lie on the good side. So this is the affected side. One of the hand of the therapist will come like this and stay at the buttocks. The other hand will stay like this. So you see, I'm holding the leg to my side now. And you rotate it like this until there's no more movement. And then you can, with momentum, swing the leg like that to get it off. If you don't want to do a thrust, you will just mobilize the SIJ like that. All these ones are counter notation maneuver. This is counter notation technique 2. Counter notation technique 3. The patient will lie, he will lie like this. All right? And this hand will be here, and they will be here. Now, this my patient has a very short hand. Ordinarily, this is supposed to be the side affected, and this is the good side. So therapy say on the good side. In the real essence, my hand should pass through this opening and out here. But because my patient has a very short hand, that will not be possible. So I can let him off this one, but put this one there. So my hand will come like this, and this hand will be on the SIS. So I will try and put this hand on the plinth while this one hold the SIS like that. So I can mobilize like this. Yes. So that is mobilization. If you want to do manipulation, you hold it tight and then you apply the high velocity low amplitude. You can choose whichever one you want to use. But I think you should be careful with technique too, especially if you are a male therapist and you have a female patient. I hope we are clear. Now, if you now try rotation, can you pause the case. Now, let's say you have done counter notation and the patient pain increases, then you have to go back and do notation. All right? How do we do notation? The patient will lie down like that stretch manipulation positioning like this. You remember this is how we do stretch manipulation. One of your hand will be on the ischial velocity, the other hand will be on the anterior superior iliac spine. You remember notation is going like this. So you can now mobilize the SI gene like this. As this one is pushing up, this one is pushing down. Okay, so you now move it like that. Okay, that is moving into notation. Or you move to the end and then you jump to this one. All right. Don't forget that manipulation and mobilization work best when you combine them with exercise. So you don't do manipulation and mobilization alone for your patients. You do manipulation and mobilization, you follow it up with either core stability exercises or Mackenzie exercises or strengthening or isometric exercises as you have deemed fitted. It's good to bring the initial pain down, but to maintain the gain of pain reduction, you need to do exercise. Thank you very much. Thank you, sir. I hope we are done. So that's it, at least. Except if they have one or two questions before I go. I've delivered my promise.
So any question?
If they don't want to ask now, if they have questions, they can contact me later. Faculty meeting upon meeting. Oh, I think I can take my leave.
In the absence of any questions, so we can call it a day for today. Thank you, everyone.
Hello, sir.
Okay.
Yes, hello?
Okay, good evening, sir.
Good evening.
Yes, sir. Please, I
I
want
can
to
hear you.
ask,
Good evening.
well
Please
done.
go on.
What about in a case whereby you did the Gilead test? Okay. In a case whereby you check, having done the Gilead test and you check and there was a LLD, that's an LLD that is due to soft tissue discrepancy. Now,
Yes.
aside doing manipulation, are we not supposed to also correct the LLD that we also see there? Because I think at times when we do either the Gilead test, as you said, most of the time one of the limb is usually longer than the other. So I think at times some prefer just focusing on the one that is shorter and just try to stretch it out. So the medium and the other will align together with the other side. So I don't know whether that concept is okay too alongside. Hello, sir.
Hello, can you hear me?
Yes, I
Well,
can
I
hear
don't
you.
know whether you can hear me, but I will just go on to respond. Well, I know what you are talking about. Now, if there is LLD, if we notice LLD, either when we are doing the Gilead test with the patient is standing, or when the patient is fine, we notice that the true length on the right side is not equal to the true length on the side. If the discrepancy in the LLD is more, they have to get more than manipulation and stretching. But if the discrepancy is less than 2 inches, which is 5 centimeters, yes, you can try to stretch it out, holding the ankle and stretching out the whole area, because that perhaps might be due to apparent shortening. There's no structural loss of any bone. So you can do the stretching or the traction like you said. But if you do that alone, that stretching or traction alone, what happened immediately? The patient puts his feet back on the floor. You know, you do that stretching or that traction in a non-weight bearing position. Immediately the patient gets his feet back on the floor, it is very likely that the malposition that the patient was before will come back. So the best practice is, if we notice LLD and it's not up to 5 inches, we can try to stretch it out or to apply manual traction in an oscillatory manner on the shortened side. Yes. Then after we have done that, we should go to the main solution. The main solution will still be to try counter notation or notation. So we have to combine the two together. Doing the stretching out for the LLD alone might not suffice, and it might not produce a longer lasting pain relief. But yes, it is good. But let us combine it with notation, or either counter notation and with relevant exercises. Thank you very much.
Thank you so much, sir.
Good evening, sir.
Okay.
Thank you so much for the presentation, sir. It has been
Yes.
very enlightening and interesting, sir. My question, sir, is for some of us that have patients that have lateral shift, which of the um, manual therapy techniques would be best to manage such individuals that come in with lateral shift?
Thank you very much for this question. There is none of this technique. The manual correction of lateral shift has its own technique entirely. Maybe we have to find another time to talk about that. We have to correct the lateral shift in standing. We have to correct it in supine lying position. And we have to correct it in side lying position. It is not part of this technique that we use at all. I don't know how we are going to do it, but Maybe we can have another time thrown line and a side line. Lateral shift is of importance because if the lateral shift is not corrected, adopt that posture again and the pain will come back. So any of our patients that show lateral shift, the priority is to start working on that lateral shift as well as correcting any other hypomobility or any other structural deformity that we noticed. But none of this technique that we have illustrated here is good for lateral shift. Lateral shift has its own method of correction. Thank you. That will take me another 45 minutes to demonstrate. Yes, we have to do it in standing, we have to do it in prone, we have to do it in sideline. The patient will come to your clinic like this. So you have to do it. No, not them. The shift will come with the lumbar spine. So there are techniques to correct that. Okay. And it's not part of what I have described. Seriously, if there's no question, I want to fly now because of my car.
So goodbye, everyone. Till we meet on the other.
Thank you so much, sir.
Okay.
Thank you, sir.
All right.
Thank you, sir.
I'm glad that I've fulfilled my promise.
Thank you so much, sir.
Yes. So,